I've had the advantage of reading Jan's story a couple of times already, and it mirrors exactly what the findings were from the lay perspective of NAP6. Knowledge, care, and effort from anaesthetists and allergists, good to excellent. Communications and systems, mainly down to the NHS, not so good. I think one could probably stop there, but obviously we shouldn't. That's if I can. What we knew before. The public, I think, are, through the media mainly, are aware of anaphylactic shock, but mainly with triggers like nuts, venom, and bees. People, by and large, don't know that you can go into an operation and have a terrible shock. And this information lies mainly at the moment with patients who've been directly affected, carers, and the specialised charities that deal with allergy. What we've also found was that there is a high variability of patient services following the life-threatening incident. Waiting times for clinics average 18 weeks rather than the ideal 6, and I think no one can really condone this situation. The other thing that we found that patients didn't know afterwards what had caused the anaphylactic shock. Very often they were given oral information. Well, that's not much good when you're very ill. It doesn't stick. And we have insisted really that at every stage the patient should be given written information so that they can mull it over and know exactly what's happened. The patient journey starts pretty much at the pre-assessment clinic, and of course the giving of consent, which has been discussed a lot in other spheres, but one common factor is that consent is valueless unless it's informed, and risks need to be discussed with the patient beforehand. You may say that, well, it's very rare and let's not alarm the patients. It is very rare, so were the number of cases of accidental awareness during anaesthesia, which was the theme of NAP5. But it is now pretty common practice to advise patients on this. And the rates of incidence of shock are roughly the same. And so there's no reason to withhold the information. The pre-assessment clinic must give the patient ample time to ask questions and gain the reassurance that they require of any aspects of their treatment. The college already produces a very good risk note number 9, which tells of the risks of anaphylactic shock. Unfortunately, this isn't available very often, and certainly we would ask that it, as a matter of routine, it's made available to patients so that they know. The other most important thing that can be told at the pre-assessment clinic, that anaphylaxis is recognised and is treated promptly by anaesthetists. So there is a certain amount of reassurance with that. At the pre-assessment, it's very important that a proper patient allergy history is gathered. This doesn't always happen, and that's been highlighted in the NICE guideline 183. Too often, the accounts of patients are relied on. And frankly, it's pretty unfair to ask the patient to give their allergy history. There are factors that will make it unlikely that they're giving you perfect information. First of all, it's a time of stress. It may be a time of pain. And for some of us, it may relate to an incident that happened 50, 60 years ago. So how on earth are you meant to remember exactly? The other point is that comes out from this, and I know it's the time-old story that there is not enough time, but anaesthetists really do need to be given more time to establish a correct allergy history, because this really, the whole thing functions around that. This is an interesting little vignette, really, which you can just sort of quickly read. Hence, it's a good example of not relying on what the patient said, because in fact, the opposite was true. Anaphylaxis is rare, which is another point of reassurance for the patient. Also, I think really of greater reassurance is the fact that 66% of the 266 cases were recognized within 5 minutes and treatment was well underway. Another 17% of cases took between 5 and 10 minutes. Now, this is probably the simplest figure that you'll see all day, but I would suggest to you it's one of the best news ones. Really, if you just look at the left-hand column, that indicates the rapidity of action by anaesthetists and the fact that basically people are being pumped full of adrenaline quickly and will recover quickly. In terms of what happens after the anaphylaxis, 25% of the patients had normal outcomes and a normal length of stay in hospital. Bear in mind, this is patients who had a class 3, class 4 incident. So it was something pretty serious, but nevertheless, with prompt treatment, they got out quickly. What we also found, though, that it was very important, and I can't overemphasize this, that the patient has proper information regarding what's happened. This is especially true as there may be quite a long wait before the allergy clinic. So to make this more straightforward, we've prepared what we hope is a straightforward and easily comprehensible letter that the anaesthetist can give before discharge to try and allay the fears of the patient during this unfortunate wait before clinic. Something else, and you'll hear a lot more about this later, that was of concern, I think, to patients is and it was mentioned even earlier, the low reporting rates to MHRA. Again, we're talking, this is out of 266 cases, so that's not good. And also, we found that there was no really direct data relating to whether patients had been referred on to allergy charities who do great work in helping people through the crisis. It came out that from NAP6, as well as from earlier NICE reports, that the investigation of incidents is variable and that there isn't always a clear pathway for prioritizing the cases that should get to allergy clinics really quickly. This table shows you the waiting times to get into allergy clinics. And really, we'd like to see column 2 in column 1 as well. A couple of vignettes for you to have a look at in relation to waiting times for clinics. The first one shows you that it can all be done absolutely perfectly, where there's good communications, a patient and a clinic that can deal with cases promptly, so that surgery was rescheduled and everything really went pretty much to plan. The second case indicates an unsatisfactory situation that we wouldn't like to see repeated too often. There's obviously room for improvement all round. We would like to see expediting and reduction in variation of waiting times, consistent investigation that always adheres to the published guidelines, and that the final information that's given by the allergist to the patient correctly identifies the culprit agent, excludes other possible culprits, and identifies the safe alternatives. Obviously, in the majority of cases, this did happen, but it didn't always. And if that information is available to the anaesthetist next time around, there can be a great improvement in the delivery of the service. And again, there is room for improvement in reporting, as we said, to the MHRA, to trusts so that they know what's really going on, and to patients' GPs. There is a lack of data in regard to the medium and long-term patient harm. We know a lot about short-term harm and how that's dealt with. The most commonly reported incidents of harm related to anxiety about future anaesthetics and sedation. It is, from the information that we do have, it's pretty safe to assume that by and large there is at least some improvement of symptoms over time. But other adverse sequelae that were reported are of great importance. Mood and memory changes was reported. Occasional loss of coordination and mobility was also reported. There also, certainly from the charities, there came a request for more analysis of the harm that comes after a shock during a cesarean section. Now, from the lay perspective, we would like to see investment in improved provision for allergy services, whilst appreciating that in the health service there is no money, therefore everything has to be balanced out by something else. So this may be somewhat aspirational, but with the increasing amount of allergies that there seem to be around, it seems to be very important. One solution that certainly came up from the charities was more use of remote access to drug allergy centres across the UK, so that maybe small centres could draw better on the bank of knowledge that there is within the regional centres. And that applies also, I think, particularly to paediatric care. Also, there was a call for more maybe sort of web conferences, because obviously people can't get together right across the country, to improve that. Now, we came out with simple recommendations that I think you'll find also across the field from other speakers. Patients are pretty intelligent, and they do need to have risks explained, and consent needs to be a genuine consent. It is very important that following the event, and preferably before the patient is discharged, which can be quite a quick turnaround time, that they are given a written explanation of what has happened, what will happen, what appointments have been made for them at clinics, what they should avoid, and by and large, that they can be reassured that just because they've had an incident of anaphylactic shock during surgery, it doesn't mean that they're likely to have it from anything else. So anything to help the patient relax, I think, is very good. And I think it's a plea that comes not only from the patients, but very much from the clinicians, that there needs to be a bit more of a standardization across the board. Also, there does seem to be a lack of good, in-depth research on the physical and psychological well-being of patients in the long term and the medium term. And at the moment, that seems to be a problem that no one really knows the extent of. So, thank you very much.
Right, so one more talk, which is brief, before we have a Q&A session.